So welcome to today's Digital and Technology Combined Special Interest Group meeting. I'm Jade Maloney, for those of you that don't know me yet, Operations Manager here at the Institute of Health and Social Care Management. Now, we are carrying on the conversation that we started in May for today's meeting around, are ICBs the opportunity to finally crack the digital nut? And our chair, David Quo, who joins me on the screen, has assembled two digital Avengers today to address NHSE's draft enterprise architecture and also to provide us with an update on the federated data platform, as well as next steps. Where do we go from here? David, I'll hand over to you to introduce today's speakers and let's get going.
Thank you very much, Jade. It's great to see everyone here today, and I'm looking forward to carrying on the conversation. I do have to say, hang on, let me just go into the next. Yeah, so the agenda, as Jade mentioned, I'm going to give a quick recap on our meeting from last time. I very much want to invite Paul to share his thoughts with us. And if possible, we can begin the conversation around this draft enterprise architecture from NHS Executive. I apologize, the update on federated data platform will have to wait for the next session of this group, because they first said they could come today, but then Palantir said that they needed to get NHSE's approval before they were able to give an update on FDP. But anyway, look, I think we're all used to following guidelines from our central colleagues. So I do apologize. We won't be able to touch upon FTP from Palantir today. We can obviously discuss it ourselves. But I'm not too worried, because we only have an hour, and I think that maybe that was kind of pushing it to have a full conversation about FTP anyway, and then hopefully we can carry on with next steps. So okay, so listen, before I invite Paul, I just wanted to just give kind of quick recap for continuity's sake. So if you remember, Tom Bell and I kicked off this conversation last time in April with the question about can we finally progress with digital health through ICBs. Tom and I think certainly, and I think many of us do agree that the NHS is very much an information driven business. Tom and I absolutely are aligned on the notion that ICBs are an opportunity to integrate care around the patient, and that means good coordination of services around the patient, and that means access to good data and information. My personal view is that data and information is great, but you also need good applications and functionality, because for me, data comes from these applications, but they're two sides of the same coin. So that's kind of where we got to last time. Last time we talked about, I went on to just kind of express, hopefully in as neutral a manner as possible, that there are various schools of thought for digital health, at work and operating in the NHS today. I continue personally to see this as a source of frustration and confusion. I don't think it's helping that there are so many different schools of thought, because they don't, each have their own validity, of course. Each can demonstrate benefit, of course. But for me, what's really needed is some kind of overarching vision and leadership, such that these various schools of thought can be more coherent, so that anybody from wherever they are, whether they're the patient, the clinician, the hospital, the ICB, social care, wherever they are in this landscape, they can understand where their digital tools fit. And I don't think we have that today. And I think that's a shame, because I think, anyway, I hope you'll agree that, more coherence would be better. And so, and by the way, things like FDP, I mean, just to remind you what I mean by schools of thought very quickly. I may have well, okay. So this is just a diagram I've been working on since we last met. I'm not intending to go through it, but you just look on the left-hand side, okay? Because I'm trying to. This is my sketch, okay? This is my ongoing sketch page. I'm trying to understand what's happening in the UK digital landscape, health and digital health. So for instance, I see a lot of chatter on social media about virtual wards. I think you do too. I see a lot of chatter on social media about electronic patient records. We know all about that. And then federated data platform. I mean, that's even talked about by the politicians. Bed management systems. I think Paul may or may not touch upon that, but anyway, there are bed management systems which we know the NHSC have promoted and endorsed. There are shared care records, which have been around for some time. And then there's a lot of talk about population health, although I don't see a great deal of advancement there, but I know there's some work there. So this is just my own personal sketch to try and inventory and take stock of what's around when we talk about digital health. And by the way, when I say EPRs, I do mean GP systems, I mean hospital systems, I mean community systems, I mean mental health. So that's just a catch-all for that, okay? And I'm not giving any judgment to any of these. I'm not saying any of these are good, any of these are bad, any of these are useful, not useful. I'm just saying they're there, okay? And then my squiggles, I won't go on today, maybe another time, but my squiggles, I'm just trying to understand in my own head, right? How these things in our digital landscape help things, help processes, help various outputs like capacity and so forth, which then should, in theory, improve final, well, when I say final outputs, these are the things that the politicians talk about, right? Reducing waiting lists. I mean, you hear about reducing waiting lists every day now from the election. Financial deficits, of course, decreased waiting times, improving quality of care. This is just, again, my own quick sketch. I'm not promoting this. I'm not intending to talk about it today, but this is all I'm trying to say and make the point is that I believe there are various schools of thought in terms of what should be done to improve digital health, to improve care. And I, for one, don't see how they all fit together today. That's really all I want to say, because, many of these purport to improve waiting lists. Many of these purport to reduce length of stay, to improve patient experience, to reduce cost. They all have these claims. What's the evidence? That's my question. What's the objective, quantifiable evidence that allows people to say, oh, yes, we should invest in this and less in that, because the evidence shows that the outputs are better. Anyway, so that's just enough for me from setting out the overall framework. What I, again, wish to do in this forum, in this IHSCM Digital Health Forum, is to engender a conversation amongst ourselves, amongst our acute, secondary, primary, social care, everyone involved, all stakeholders, so that we can understand these various points of view better and hopefully, come to a more coherent view. Is that okay? And so therefore, kind of in the light of that, I would like to invite, I'd like to invite anyone who wants to speak about any of these and maybe feels strongly about why one element of this digital landscape is kind of more urgent or valuable or important or beneficial than another, and how it fits with the others. Is that okay? So within that introduction, if you like, I'd like very much to invite Paul Rylands to take the floor and maybe give us, I don't know, 10 to 20 minutes conversation, Paul, about your views on this. You know, maybe you have a great product that can really help things here. Maybe tell us why, and then we can again have a kind of group conversation. Is that okay, Paul? Are you happy with that intro? Because if so, then I would say, please take it away. I will stop sharing.
Okay. Well, it's you've provided the perfect springboard, David. You've opened up so many topics, and I think I'll start off with something that may sound controversial, but I'm not deliberately trying to annoy people. So let me put that caveat in place first. Historically, when you look across health and social care, the approach has always been some form of silo. And that in itself has created many problems. And now we're at the level where we want to raise those silos to ICS or ICB level. Now, they're still silos, they're just bigger silos. And with that comes complexity. So 42 silos will then try to exchange information at some level at some time. And how they do that, you know, remains a challenge in itself. So what I'm proposing is to sort of shift away firstly from that silo mindset so that we can have, let's say, an infrastructure that is not tied so closely to organizational structures. And therefore, if an organization changes, we're not having to reinvent the wheel or redesign systems. That organizational change should just dovetail into the overall approach. Now, obviously, EPRs are a very interesting subject, and whenever we talk about EPRs, we're never sure about whether we're talking about community care, primary care, secondary care, etc., or mental health even. So how about we look at an EPR as a clinical repository? Yeah, and this is where my conversation's going, is around repositories rather than systems. I think NHS and social care need to stop thinking in system parlance and start thinking of data repositories. Okay. Now that in itself obviously brings some challenges, but it also brings some massive opportunities, particularly in flexibility. So if we have a clinical repository, what will go in there? Now, there's lots of people who already want to drag the conversation over to the classic EPR big behemoth systems, and that's okay. But I think they should be just clinical interventions should go into a clinical repository. So things that are happening or have happened to a patient. And that can be then across the board. People can dip into it at the right level to get right information that they need about a particular patient. That also satisfies a research. But I think the important piece is that everybody should have skin in the game. So the GPs, your CCIOs, your clinical leads, they should be the curators of this repository. And they, like, very similar to an open EHR type approach, they decide the structure up front. Most of it is already built and designed. So it will be the changes of new things that are coming in. They would curate the repository. Now, what that does is it removes the focus from integration of disparate systems to a focus on UI, focus on analytics, focus on better data flow. Now, if we extend that, I'm talking about a clinical repository because I think that's everybody understands that, because that's usually where the conversation starts and ends in most cases. But if we think about the patient journey as a whole, we realize that the clinical aspects are only one part of it, albeit a very big and important part, but they are just one part of it. And the other parts, I think we've identified probably about 16, and your diagram comes very close to that, actually, David. So it's encouraging that I think we're on the same wavelength without realizing it. So let's look at something like patient transport. Why can't we have a transport repository? And therefore, we're not tying organizations to using technology that, let's say, certain transport providers have already got, but we open the doors to say, well, NHS, social care, etc., will decide what they want in transport, what data structure should be in transport. And therefore, if somebody wants to focus on net zero initiatives, etc., then that's much more easy to accommodate than going to suppliers and vendors and saying, can you put this in your system? Because it gets very expensive. And I'll give you a great case in point. If there was a simple change to the current structure, let's say in EPRs, and we'll say there are, and I'm talking acutes. So let's say there are 120 acute trusts, each of them have their own EPR. If somebody wanted to make a change that was nationally beneficial, and let's say that change was £150,000, which is quite microscopic in the grand scheme of things. When you look at it nationally, that's £18 million. Whereas if we have a repository approach, the cost would be £150,000. There would be no replication of the same, effectively the same change being rippled throughout individual EPRs. It would be done, does the repository actually already accommodate that need? And if so, then it's just a change to the business logic and a change to the front end. And so once we divorce all those layers, GPs can say, I want the front end to look like this. This is what GP land needs. And that doesn't affect anything else except the UI. The data is effectively the same. And the same can be said for community, same can be said for acute trusts. I don't profess to have all the answers, but here's the starting point. So what other repositories can we think of? I've touched on transport. So we could have bookings, and that includes bed management. But that includes bed management across everything. That includes acute community trusts, extra sheltered, residential homes, nursing homes. Anywhere a patient will reside is effectively a bed. Now, even if that is in a corridor at the moment or in a chair, on a chair in a corridor, so be it. But that can also accommodate discharge lounges. It can also accommodate virtual wards. So you manage a virtual ward just as you would a physical ward. You know exactly what patients are in your virtual ward. The only difference is you're doing remote monitoring rather than physical monitoring as you would in the trust. Other repositories would be delayed transfers of care, patient delays, yeah? And the reason I'm saying that we should have a repository for that per se is that these things are not clinical. They don't need to be held in clinical systems, and we shouldn't need to wade through clinical data to understand the pattern of delays from the single patient level all the way up to national level. We should have that information at our fingertips in real time all the time. And the same with bed capacity. A great case in point with the COVID example back in 2020. We tried to speak to Matt Hancock, sent him a letter and said we could show every ICU bed across the whole of London in real time. All you have to do is give us the go-ahead. And we never got a response, for that's by the by. But we could have done that, and everybody would have known, without fleets of people running around trying to grab data into spreadsheets, they would have known exactly how many beds they had and exactly how many patients were coming in that were COVID positive. That could have been quite a game changer, but I guess that's history. Other repositories could be pharmacy. We separate pharmacy because then you can do research again without wading through personal clinical data. I'll touch on appointments because that's an interesting piece. Historically, appointments have always been an NHS-centric thing. Everybody talks about appointments and they instantly think about inpatient, outpatient. But what about all the other appointments a person may have? Dental appointments, social care appointments, Whether that's domiciliary care, whether it's blitz cleans for houses, it doesn't really matter. They should all be tied together. So, and these are things that don't go into a patient record because they haven't happened yet. They are merely a scheduling event. So if we start separating these, let's say, discrete functions out into repositories, the flexibility then becomes really, really quite massive without having to bog every single instance down into, let's say, the clinical rigor that is expected from a clinical repository. I could go on and on and on about this, but I won't. I'll try and open the floor. But I guess my closing point is that EPRs in the general term have been used for so long by so many people that many really struggle to think outside of that EPR approach. And I think that is possibly one of the biggest challenges that NHS et al. Will have when it comes to thinking of a new approach. I'll leave it there, so give people time for questions and responses.
That's great. Thank you, Paul. That was very interesting. I'm sure there'll be various comments. I do want to, let's see, I'm just picking up some comments in the chat. So Mary asked about whether there are other things we couldn't talk about in the way that Palantir declined to speak today about FDP. But that's not my understanding. My understanding isn't that they were reluctant to speak because of election purdah. I think it's a standing protocol which apparently Palantir has, probably as a result of the contract they have with NHSE, that they have to get approval whenever they go on any public platform to talk about FTP. That's my sense of why they weren't able to talk today, not really about election purdah. So so that's my guess in answer to Mary's comment. And then I see another comment in the chat from, let me just try and get a hold of this. From Andrew, regarding consents. So if I understand Andrea's comment correctly, she's suggesting that it would be valuable to include patient consents in any mechanism, I guess like a repository, but anyway, to consider the importance of patient consents as documents and that need to be shared in an appropriate manner. And I personally totally agree with that. Andrea, have I caught the essence of your comment in the chat?
Yes, absolutely. Basically, we moved from 100% paper-based consent to now having both a digital consent that is sent to the patient and they do it by the app, and that gets then immediately uploaded into the EPR. So the surgeon has immediate access. We have immediate access. Everyone involved in the care of the patients knows this important information. Consent need to be then revisited if we want more blood samples, or if there's a certain amount of time. But just for this 6 months of change, we've got much more samples incoming. The retrieval was so much better because the communication was digitalized and hence was much more facilitated. So I agree, it was very good.
No, that's terrific. It's something we don't, we don't talk enough about. I think, can I just check, when you talk about a biobank, is this in respect of research, or is it in respect of diagnostic testing? What do you mean by that?
No, it's research. We
research,
are Cancer Biobank, yes.
Okay.
And I see a message from Mary. So our consent form has, in order to be legally viable, it does have the full name and surname, date of birth, and NHS number of the patient. There are also some rules in regards of dates. So we need a witness to the signing, and the date of the witness can never be even a day after the patient. Sorry, a day early of the patient. It always, there's a very complicated rules.
Yeah.
I can't. I'm not a consent coordinator. I'm just a quality coordinator. But yes, it does have. But then, of course, this EPR allows us to decide who to share this information with. So not everyone in the whole trust has access to this content.
Sure, sure. No, that's a great Paul. You want to come in?
Yeah, I do, because this is a really fascinating area. And
it is.
The first question that springs to my mind is, why does consent need to sit in, let's say, a silo-centric EPR? Why? So we could say, and this would be driven by researchers and GPs, etc., all those people involved in consent. And that consent could extend not just from bio things, but assessment consent. For assessment notices by social care and health. So if that in itself was a repository, and it's almost a consent and permissions repository, that then could be coordinated with all the right specialties.
Yeah.
And it could be transferable. So no matter where that patient wants to go, if let's say they live in Sussex and they're up in Scotland meeting relatives, that data is available to everybody.
Yeah, no, that's
obviously at the right time. But for research, then you'd be able to jump into a repository that is a national size thing. And that would be very, very meaningful, I suspect. Yeah.
Yeah. Before I bring Mary in, I totally agree. Just very quickly, so I think we seem to be edging towards a more, shall I call it, a generic consent model. Okay, which may be EPR agnostic, dare I say, that sort of thing, which I think sounds fascinating and very important. I mean, there's all sorts of consents, right? There's consent to operate, which have been around for a long time. There's consent to share, certain information. So anyway, I think it's a great conversation. Mary, please do come in. Great to see you.
Well, on consent, you have to, for procedures and other things, you have to give informed consent.
Right.
You can't give blanket consent for future procedures about which you and the people doing the procedures at the moment have no information. So biobank is a particular setup, because I was on the GPES IAG when we looked at biobank consents. And the thing that is obvious is that to get into biobank, you had to be thoroughly informed. And there was no question of consent to participate in biobank being anything except informed.
Informed consent, yeah.
Different from the things that have been coming up on Twitter, where patients have been giving consent for procedures carried out by physicians' associates, which are, it is not clear whether the patient was aware that the person to whom they were giving consent qualified to start off with. This is going to throw up a whole lot of legal issues. I don't know how you can have a generic consent form.
Correct.
Each thing will be specific.
Specific.
To have a consent form, there was one hospital that stated on patients being admitted or signing up for procedures, that they were a research-based hospital, and they would like permission to retain and use any tissue removed for future research purposes.
Mm-hmm.
And patients were very happy, on the whole, to agree to this. I mean, when you've got rid of your appendix, someone else might as well benefit from it. You lose interest in your appendix. But it is a requirement that you should give consent for it.
Yeah.
Giving consent for a course of treatment doesn't necessarily mean that you have given consent for any other treatment, especially if the treatment and the risks and consequences of the treatment have not been fully explained. And because people have explaining a complicated procedure to someone who is under considerable stress already requires, I think, to have it documented and to have the documentation. So if you're going to have a course of chemotherapy, you don't want to say the MDT thinks this is the best course for you. You want to know what the course is, what the options are, and you don't want it all in one 10-minute consultation.
No.
Down so you can go away and think about it.
This also touches on, Mary, if I'm not mistaken, this also touches on mental capacity as well, doesn't it?
Yeah.
Because again, you can't assume somebody has mental capacity. You have to know that when they're giving permission for something, they actually have the capacity to understand what you mean.
But also, mental capacity is individual to the circumstance.
Mm-hmm. Yeah.
That if you don't explain the things properly, you can't assume that they have mental capacity for that particular.
Exactly.
It's individual situations.
Yeah, exactly right.
Helen, can I bring Helen in, please?
I was just going to say very quickly, because we are National Institute for Health and Care Research, consent, we obviously manage systems like the Clinical Practice Research Data Link, which are 16 million GP records that patients have consented for their data to be made available for research purposes in an anonymised format. You talk to some GPs, they may not even know that they're part of this system, but there are 16 million records there. That is a blanket consent to make your data available for research purposes in an anonymised format. So there's a difference between an anonymised and unanonymised, because I also sign up to the bioresource. So you've given a genetic sample and you've consented to be made available for future clinical trials in areas that you are particularly interested in. So that is a non-anonymised agreement to consent to do research. But you can say that the research environment is very different from the clinical environment where you're consenting to individual procedures to be conducted on you. And there may well be you have to keep them separate to a certain point in time. I think that was my only point. I would also just say very quickly, this week I was at Coventry and Warwickshire Partnership Trust, which is a mental health trust, and they are looking at their digital strategy, obviously. And because they are quite a small trust and mental health only, they're looking to build a data warehouse of their own clinical data, and then have some form of something like Power BI to get information out of it, and then request additional data from, say, University Hospitals Birmingham when they need it for the larger portion. They see that as a more efficient route forward than contributing to a larger data set, because they want to be more research active and they want to be able to control that data.
Okay. Sorry, just to clarify, that data warehouse for that mental health trust, that's specifically about a research data warehouse.
All of their clinical data for which they can use for research purposes.
for research, because
Yeah.
in other words, that's a separate data warehouse or repository to their mental health EPR system, which they would use for day-to-day care treatment. Yeah. Okay. Understood. Very good. Mary, did you want to come back in? Yes.
As well, for anonymized data, that it is quite easy in many cases to re-identify a patient, and if you can't give consent for future procedures legally. You can't consent to something you don't know about. You can re-identify an individual patient, very often, particularly if the condition is unusual or uncommon. So you could, take my brother, you could re-identify him from an anonymized database by just putting in male survivors.
Right. Sure.
Urine disease, age.
Yeah.
The same applies to even quite simple things like, which are not particularly controversial. You had an appointment on at this hospital, and you can do this with women who have born children, have 3 children, different hospitals, you've got the mother. How significant this is in an age when everybody seems to know everything. Is a different question, but you can't build a consent-based data set or repository. And that.
Okay, so listen, if you don't mind, I don't want us to spend this whole hour on research, even though maybe we should spend another hour on research. But today is meant to be a kind of higher level conversation. And please believe me, I'm a huge fan of research, and I believe research doesn't get enough airplay when people talk about digital health in the NHS. I absolutely believe that. So don't think I'm trying to underplay the importance of research. But I do want to try and stick to the agenda for this particular conversation, which is a higher level one. And so if we could possibly get back to that wider agenda, which is about, how do these big components in our landscape that are there, how do they fit together? Okay, so but I do have a couple of comments from what Paul said, if I may. So it's like, okay, I think I hear you saying that you're advocating the value of having repositories. Okay, and I think I understand that, but maybe we can talk about that some more, not least because a lot of people talk about repositories. Okay, and I suspect it may be one of these terms where there are varying kind of flavors of repository. Okay, so because I mean in a way, let me ask you this then: do you think this concept of repository is a common feature, or is in common with other things in our landscape, like a shared care record? Okay, because a shared care record, right? And remember, there's supposed to be one for every 42 ICS, and I think there is. Anyway, shared care records are there, okay? And as I understand it, shared care records are repositories that take data from EPR systems
Yeah.
one way or another. I mean, okay. I mean, we can argue how well they do them and so forth, but
Yeah.
I think that's the intention. That's the strategy.
Sure.
Okay.
Sure.
And then I would also ask, just very quickly, I also think that the federated data platform, which is very much in our landscape, for me, that's another flavor of repository, because if I understand it correctly, that system is meant to take data from varying sources and put it into a repository.
Yeah.
So I guess I would just maybe ask you, Paul, because since you raised, I mean, you seem to promote this concept of repository so strongly. You know, how does your perspective or flavor or approach to repository differ from these other two that I mentioned?
Yeah. So
if it does.
Yeah. Well, you've raised some great points. So firstly, I'll talk about the FDP and the other system that you mentioned, and without sounding derogatory, BI platforms are parasitic. Without data coming in from somewhere, they are of no use to anybody. Yeah. So, and that data will be under, in technical parlance, ETL. So extract, translate, load. So they extract it from the source or donor system, they translate it or to normalize the data, and then they load it into the repository. But that's a BI repository. And the only challenge with that is you can't get back to source. You have to trust that somebody has translated and transformed that data correctly. You can never get back to line item to say, I categorically know that that data is true and accurate because I don't have access to the individual EPR. Yeah, I only have access to what the business intelligence is telling me.
Yeah.
So in a real repository, so I'm not talking about taking data from places and dumping it somewhere else with a bit of translation and a bit of AI on top of it. I'm talking about having a clinical, I'll use clinical because that's the easiest thing, a clinical data repository where the data resides. Now, how you want to slice and dice that data is entirely up to you, but you can always get back to source. You can always interrogate an individual line of somebody's record and say, I know that is fact as close as I can get without actually talking to the person who input that data. I know that is true and accurate. Yeah. So
can I just check though, where are you getting the data for your repository? Because no, because I mean, are you, presumably you're not getting it from your, what you refer to as a behemoth, other people call monolithic EPR system, including GP systems, by the way. So I think we're meaning, correct me if I'm wrong, you know, these behemoth monolithic EPRs, I think you would mean EMIS, System 1, Cerner, System C, Epic, Medita. Okay. So and the social care equivalents. And so then are you saying you don't want to have anything to do with them? Or are you saying, no, you still need to have, you still need to draw data from them? What are you saying there?
Yeah, okay, well, that's a very interesting question, and I'll try and be really, really brief. There are times when data in incumbent systems is probably quite valid. Yeah? And whether somebody wants to transition away from this behemoth monolith type approach, that would take a lot of time. Yeah, but it's still very doable. But the thing with, once you want to start looking at a broader picture, you should be able to, without spending millions or billions of pounds upon integration of disparate and separate systems, embroiling yourself in the extract, translate, load scenario. Yeah, you should be able to say, here is a common repository. It is the source data, and the people who curate that repository will allow me access at a certain level depending upon who I am. Yeah. So if it's a research, somebody puts in, I've got a request for this research, whether it needs comms going out to individual patients to say, we need your consent for ABC, that's a different story. But if you try to do that with separate EPRs, that would be an absolutely insurmountable challenge. It would be really, really difficult to do. So just to touch on Mary's and Helen's and Andrea's point, the consent is a complex thing, really complex. We've had 3 inputs and everybody's showing complexity straight off. So these are the people that should be the curators of, let's say, a consent and permissions repository. The people who understand the nuance of all of this, rather than it being bound in a vendor's EPR. Does that make sense, David?
I think so. I may need to follow up with you to understand more clearly.
Please.
But Helen, please come in.
Paul, isn't what you've just described like the Discover Now platform?
I don't know the Discover Now platform, so I couldn't tell you.
I'll send you a link. So it started off, it was originally, it was Research Council funded at some point. AstraZeneca are also involved, and there's basically, it's also Imperial Healthcare Partners are now involved. There were a series of these data platforms. They've pulled information together in a repository.
From source systems, yes.
And then they have a layer of analysts that they've all contributed to that give access to information to whoever requests it, depending on the permissions. And that it's that layer underneath that took a lot of time and effort to get right. So now you can commercially access that platform. I know it mainly as a research tool, but it's broader than that. And the fact that, so there was one around imaging diagnostics and pathology. There was DataCan is a cancer one, but this one is based down here. I can send you a link to it, actually.
Please do.
Just
Helen, just to jump in, because I know we haven't got a lot of time. This sounds great, and it is very, very clinically focused, and I appreciate that. That's not a criticism. But if we have all these repositories, and we talked about the shared care record, which David mentioned earlier, what a patient wants may not reside in a single repository. It may reside in a number of them. But it allows let's say a front-end designer to say, well, I can design my systems, and if the landing page is, let's say, somebody's clinical information, they're drawing it direct from the clinical repository. If they want to say, well, I'm entitled to transport, and therefore I want to be able to link my bookings or appointments with transport, there's 2 more repositories. There's the appointments and there's the transport. And if the transport can't deliver, event-driven data should say, rearrange the appointment or cancel the appointment and cancel the transport. And this has nothing to do with EPR. EPR doesn't need to be involved in things like that because it hasn't happened yet. So if we think on that terms of the clinical repository only records what a patient has had done to them or is having done to them, and whether we need to call the consent repository to say, has this person consented? Or has this person booked transport to go home post this appointment? All of this can be dynamically drawn. But the flexibility it provides is just absolutely humongous. So if somebody, let's say a researcher, wanted to say, I want to understand how transport works within the NHS as a whole, they would be able to make a request to that repository. The curators would look at it and say, yes, this is bona fide. Yes, we can give them the data without exposing anybody. We don't have to pseudo-anonymize it. And they could play to their heart's content with a data set. And that could be really, really significant, particularly when we start looking at patient delays, particularly when we start looking at appointments. That's the key to waiting list, is understanding what the appointment footprint looks like. Without having to wade through clinical data, we can just look at what is the most important. I'm sorry, I'm sounding ranty now.
No, not at all. And so, okay, I mean, have you got an example of the kind of repository that you're talking about?
Yeah, I have. Probably we don't have the time right now, but I'm happy to go through that again. I know Helen's seen it, and I'm having a discussion with a few people over the coming weeks. I've literally just had a conversation with Jess Morley, who's big on the AI front, and her statement a couple of weeks ago from the Nuffield Trust Summit 2024. Herself and 3 or 4 others were talking about AI and data. Excellent presentation, because they all agree, and so does Rachel Dunscombe, CEO of OpenEHR, that the focus shouldn't be on AI. The focus should be on getting good quality, clean data first. The AI can then sit on top of that, but without that clean data, and this is why I'm a big advocate of this repositories approach, because people would have skin in the game. Researchers would say, this is how clean we want the data to make our research more and more accurate. Yeah. And the people who curate that repository could hold that in mind. All the CCIOs, the clinical leads who are interested in data, they could all contribute and curate that repository to meet multiple needs.
So let me try and understand. So if somebody like a GP wanted to understand a patient's medication history, if Mary had a patient and wanted to know that patient's medication history, including medications given across, I don't know, multiple trusts and GP episodes. GP encounters, where would Mary go to in your repository model for this data?
Well, it makes sense to have, let's say, a pharmacy or medications repository, doesn't it? Yeah. So then the likes of Mary or somebody in acute trust can say, show me the medication pharmaceutical footprint of this person. And we can say with a massive amount of certainty, here are all the prescriptions, but they were never collected, let's say. So there's a research point in itself, isn't it? How many people get prescribed meds and they never actually go and fulfill the prescription? And then you say, well, if they fulfilled the prescription, the chances of them actually taking that medication have significantly increased, haven't they?
No, I understand the importance of how there are many valuable questions that could be asked, but where would you get that medication history data from, for your repository?
Oh, for the repository. Well, this is where the sort of paradigm shift is, because instead of inputting that data into an EPR, from the user interface, it would go into a different repository. If there was an intervention.
So you're wait a minute. So you're asking the, let's say, an outpatient consultant in a hospital, that patient goes to a consultant in a hospital clinic appointment, and that consultant prescribes some antibiotics. You're saying, in order for your repository model to work, that consultant in that clinic in front of that patient, instead of entering that antibiotic prescription into that hospital's behemoth EPR, that consultant should instead log into your repository and enter that prescription.
Yeah, well, my repositories that I've worked with over the past decade have got nothing to do with clinical stuff. But in the grand scheme of things, ideally, yes, that UI that the person uses, they say, well, I've just met this patient, that goes into the clinical repository, and I'm prescribing this, that goes into the pharmacy or e-prescribing repository.
Okay, so you're essentially offering an alternative method of working from today's. I mean, this does require
transition. Yes,
Okay, so this is going to take some time.
Well,
it's
it is, you're right. It is for some things. You're absolutely right. But let's just focus on some non-clinical stuff right now. For bed bookings, appointments, for bed bookings, appointments, transport, patient delays, nobody does it the same at all in any way. And none of it is linked to EPRs at all in any way, with the exception of appointments and beds, which is a PAS system. Yeah. So you could actually say, well, look at all the functions that the PAS system is doing right now. And if we can turn those functions off and use a centralized approach, then why should we be spending millions and millions and millions of pounds?
okay.
All we need to do is have a.
Okay, so look, I can see where we've only got a couple of minutes left.
Yeah.
I mean, for me, this has been valuable because, again, I keep saying, and I'll keep on saying that what's really valuable in this is that we carry on the conversation. Okay, and because, yeah, particularly from people that have different points of view, because yeah. So therefore, thank you all very much for your contribution for carrying on with this conversation. I definitely want to continue it. I want next time for us to hear from people like the FDP. I would like to find somebody from NHSE if possible, maybe from One London, who I know those people are part of that construction, to talk about this new enterprise architecture, which theoretically should be bringing all these things together into a coherent whole. So,
well, yeah, it's event-driven rather than.
I'm encouraged by that. So I think, you know, we've kind of run out of time. I found that interesting. I hope you have too. Jay, when is our next meeting? Is it October?
It is. Our next meeting is the 4th of October, where we hope to carry on the conversation then. It's clear an hour meeting is not long enough. It needs to be a succession of several hours. But also, we've got the opportunity to contribute a session from this group to our national conference, which will take place online this year on the 17th of October. It's a full day event. I will send out a save the date for you to add to your calendars. But it'd be great if members of this group would like to contribute to a session, 20-minute session. And also we could have a roundtable discussion following on from the 4th of October as well. Until then, have a lovely weekend, everybody, when it comes for you. And look forward to seeing you at another event soon. Thanks so much for taking part today. Take care.
Thank you all very much. Thank you.
Thanks, David. Thanks, Paul, Mary, Helen, Andrea. Thank you.